Hello, everyone. I hope you can hear me. And welcome to this webinar of ROPCA. And my name is Thiusius R Savarimuthu. And I'm one of the co-founders of ROPCA. Today I'll talk about the development of R2, our first product, and the story behind the robot, how we developed it, and so on. I'll just wait a couple of minutes to make sure that we have everyone who wants to joining us, and then we will start. Okay, let's move on. Okay, so the outline of the talk is the following. We will start with the initial idea generation. I'll tell you a bit about how Søren and I came up with the idea, and what the initial aim was with the project. And then I'll take you through some of the steps that we did research-wise in order to have a good start on the project. Then at some point, ROPCA was formed as a spin-off company. We started to develop the prototypes for the company, and finally I'll end the talk with some of the steps in the CE marking that I learned during this journey, and hopefully this can also inspire some of you if you have similar thoughts. And feel free to ask questions while I present. I don't mind. Actually, I prefer having a conversation. So if any of you have any questions, then please just ask them while we go. Okay. So before I go into the ROPCA story, I want to start with some of the research and general ideas behind control of medical robots, because I think it's important to have a focus on why do we want to do an automatic ultrasound scanning robot, which Arthur is. So there are many different ways to categorize medical robots and control of these robots. You can have a look at the way they are optimized and the way they interact and so on. One way that for me makes sense is to have a look at how do we actually control the robot? What are the interaction levels between the operator and the robotic embodiment, and how can that be used in order to talk about robots and think about their use cases. And to simplify it, I have chosen 3 different steps. The first step, or the first category, I call teleoperated robots. So these are robots that are remote controlled by human beings, typically doctors, and robots that basically in the essence mimic or reproduce the same motions as the doctors when they execute the task. So for instance, the well-known Da Vinci robot from Intuitive Surgical is a teleoperated robot. That's a surgeon sitting in a surgeon console, and they remote control every motion of the robot in order to operate the patient. Now, these robots have the advantage that the strain on the operator, the surgeons themselves, can be lowered during the operation because you can basically remote control each motion. You don't have the physical strain on the body while you operate, but you still have to mentally cope with the challenges during the operation and, of course, know how to perform the operation in order to remote control the instruments. Then there's a second category of clinical or medical robots, and these are robot-assisted systems where the robot assist the surgeons or the clinicians in performing the task, the surgical task or the clinical task. This could be, for instance, a CyberKnife system, or it could be the Marco system, other systems where the robotic part of the interaction is that they perform a certain pre-planned task. The plan has been laid out by the surgeons or the clinicians, and then the robot basically helps out carrying out the plan. And for instance, in the Marco system, this could be in order to drill out a part of the bone, the robot basically makes sure that you stay within the margins that you have specified during the planning phase, and that the safety constraints of that particular task is obeyed. However, it's still the surgeon who carries out the task itself and motions the robot to do part of the task. Another use case could be, for instance, robots used to place screws or take biopsies. Here we also have typically a robotic arm holding a guide to the placement of the screw, or for the biopsy needle to pass through. And in this way, you can make sure that you have a very stable and precise needle guide for taking out the biopsy sampling. So teleoperated robots, you have the human always closing the control loop, where the human has to basically issue every command, and then the robot carries them out. Robot assisted systems, here you have robotic systems that help out the part of the execution. So you as a surgeon do not need to always issue all the commands to the robot. However, you have a pre-planned task that the robot helps executing. And then you have the systems where you have the fully automatic systems, where you have taught or programmed the robot to execute a task. And this has been done in a general way, so that once the patients are in the system, or the system is applied in the task, the robot basically carries out the procedure itself. And we have very few of these systems in the world. operating, and we can discuss at the end maybe whether ROPCA and the Arthur robot is one of these automatic systems. I don't think we are there at all, but it's towards the transition towards these automatic systems. By definition, we are not, and of course, for the safety of the patient, we cannot be in the current version. But I think, in general, this is the trend we see in medical robots, that we want to have more and more automatic systems out there. So just to be clear, Arthur is not a fully automatic system in the robotic sense. However, I think there are some trends towards this in the community. So this is just to set the scene. We have a lot of these teleoperated robots. We have a few of the robot-assisted systems in hospitals, and then we have again a very few automatic systems or semi-automatic systems. Okay. Just check if there are any questions. Not yet. Okay. So how did we start with ROPCA, and how did it all begin? My co-founder and I, Søren Andreas Just, we at that point had kids in the same class, and we were sitting at this parental meeting where you know, both a bit tired of a long day of work and so on. So we were sitting in the back and small talking to each other, and I found out during that evening that Søren was working with arthritis, and he was doing his PhD where at that point he was taking biopsy samples from patients' finger joints, among other things. And I told him about my research in medical robots, and then one thing led to another, and we were talking about how could I help Søren in taking these biopsy samples. And one of the things that was a bit challenging for him was that he had to use a ultrasound probe while taking these biopsy samples, and and controlling the ultrasound probe, holding the ultrasound probe on the joint while taking the biopsy. And it was quite natural for us to reach the conclusion that maybe we could have a robot hold the probe in a place that Søren would basically drag and move the robot to hold the probe at a specific spot, and then he would have both hands free to take the biopsy sample. And that was basically how we started the whole journey with Arthur. Immediately after this parental event, Søren and I started to talk about going into a research collaboration about this topic, and we applied for a small research fund where we got from Energi Fyn in 2016 approximately 250,000 kroner to investigate the possibilities here. And based on that funding, we then started to look into the problem and create this platform that could basically hold the probe for Søren while he was doing the biopsies. Once we started working on this, what happened was that we quickly found out that, or Søren found out that when the robot was holding the probe, the ultrasound image became more clear, and the noise in the image, according to his inspections, were reduced significantly. We believe it was due to the very steady position control of industrial robots that basically led to that what you see in micro motions in the hand while you manually hold the probe. Those micro motions were removed immediately when the robot was holding the probe, and that led to more stable images. So based on that, Søren suggested, why don't we have the robot actually scan the patients as well? And yeah, that then kicked off a different sets of research activities that led to the robot that we have today. So I'll go a bit more into that. So here you see the start of the process, the Energy Fyn research grant. And with this research grant, we did a lot of groundwork in order to figure out what is the mechanism behind a good ultrasound image. How do doctors scan patients? And based on that, we then applied for a continuous grant, internal University of Southern Denmark grant. And this grant gave us some money to actually hire an engineer in SDU to continue build the automatic scanning system. And at the end of that grant, we created the spin-off company in late 2019. I think it was November or December 2019, and then our first employee started in the company January 2020, and then in 2022 we got the CE mark for the robot. Okay, so one of the main part of the first project grant was to investigate what was a good ultrasound image in hand arthritis. How do we get a good image? How do we scan the patient? What forces were involved? How big motions should we actually have the robot do, and so on. So in order to capture that, we created a tool. This tool had the ultrasound probe of the, I think this is from a GE E9. And then in addition to that, it also had a force torque sensor at the end of the probe, and it had a magnetic tracker which could track the position of the probe. So having this device, we asked a number of doctors at the hospital to show us how to scan a patient, scan different joints, and create a data set of images of other employees at the hospital. So during this phase, we collected a lot of data, and this data was mapping basically how was the probe moved during the scanning procedure. It mapped the forces and torques involved in the scanning process. And we found out, for instance, that the pressure, the force that you apply on the joint is very important in order to get the right information for detecting the disease activity in, for instance, RA. We also found out that there is a limit to how little force you can apply in order to get clear images, for instance. And we also saw that the motions of the probe itself during the scan was actually not large, and overall the search area was limited as well. So all of these factors were then included in the next phases of the development. Then, so this was kind of hardware investigation. We wanted to see range of motion, forces, and accelerations, and so on. And then on the side of that, we also developed algorithms for detecting the joints, the finger joints. We at this point we did not have AI algorithms for hand detection on a detail level that we needed. So we created a good old-fashioned vision pipeline where, based on the image you see here on the left, we would come out with the results showing where do we have the joints of the fingers that we were interested in scanning. And this vision pipeline was then the base on the first landing point for the scanning process, where the robot could then scan the patient. So these initial points were used to tell the robot you need to start the search for instance, the MCP 1 joint at this particular location relative to the camera, and then based on that we could then do the ultrasound search. This was kind of the first version of the robot where we did everything based on image pipeline, where we built everything from ground up, including the vision pipeline and the force pipeline. So based on these developments, we created the first platform. The first platform had a stereo camera looking from above down on a glass plate here, where the patient or the test subject at this point, we did not have any patients at this point being scanned by the robot because it was purely a research platform. It was mostly test subjects from the university. But in any case, the test subject would place their hand inside this shaded box, and a stereo camera would basically detect, take images of their hand, and based on this, we would then estimate the 3D positions of the hand relative to the camera. Then we had a universal robot arm equipped with a force torque sensor, and then the ultrasound probe from the ultrasound machine mounted to that. And this robot would then be calibrated to the stereo camera system in order to transfer the positions of the hand relative to the camera. They would then be transferred relative to the robot base, so that we could issue the robot to move to the landing point. But on top of that, we also had a motion sensor below the table looking up at the hand from down. That's why we had the glass plate here. And this was because we wanted the system at that point to be able to track hand motion during the scanning. So for instance, if the test subject moved the hand while we were scanning, then the robot would be able to compensate for these motions so that we would still keep kind of the joint in place in the ultrasound image. This is, of course, something that is quite natural for doctors to do while they scan. However, it's quite difficult to make sure that the robot or the test subject doesn't move relative to each other during the scan, and therefore the scanning area is lost for that particular subtask. So we implemented a motion tracking sensor that would always keep track of where the hand was and whether this position moved during the scan. And this was including actually the motions of individual fingers, because one major problem we had was that the robot, once it started scanning the patient or the test subject, it would actually block for the 3D view of the 3D camera, because when this part moved down here to scan the hand, it would actually block part or large part of the stereo camera view of the hand, and that would lead to the motion track, or sorry, the vision pipeline tracking of the joints more or less unusable. And that's why we had the tracking system underneath the table to compensate for that. However, in later iteration, we got rid of the motion tracking below the table and replaced it with a touch sensor on the screen itself, and also reduced the form factor quite a lot for the robot. Now, in order to keep time, I'll move fast forward, because this process of developing the platform went through a lot of iterations, including help from external partners and also a lot of conversations with doctors. And at the end of the day, we ended up with a platform looking like this, where some of the elements you can still see from the very first idea. So for instance, up here now in the current platform, we actually have a camera system. We have a RGBD camera now and not a stereo camera, but the purpose is the same. And this camera creates an overview image of the hand of the patient when it's placed on the touchscreen here. And we still have the robotic arm now. It's not a UR arm anymore, it's a KUKA arm. And we have the probe mounting. In this arm, we don't have an external force torque sensor anymore. The forces are calculated by the controller itself with sensors sitting in the joints. So we could remove the external force torque sensor. And then, of course, the form factor of the robot itself, the platform and the footprint of it has been reduced. On top of that, we have added the touchscreen, which gives us the ability to display instructions to the patients and communicate the process while being scanned. We also have audio feedback and instructions built into the system, where we can inform the the patients of what is going to happen during the scanning process, which of course is to ensure or at least help with a good user interface and experience for the patients while they're being scanned. And then we have also added in the system a capability of being applied to many different ultrasound machines, and not only one single system that it was developed to in the beginning or for. Okay, so and here we basically have a more systematic view of the system, where we have these 3 vendors of ultrasound machines right now that we support. We have GE Healthcare machines, we have the Siemens ultrasound machines, and we also compatible with Canon machines. Not all types of machines from these companies, but some of them. The major or the main characteristics that we need from these machines are, of course, that they need to perform well on the clinical tasks. So the doctors have to approve that that the machine is sufficient quality to detect the signs of disease activity. And based on that, we can then make sure that it has the technical capabilities. For instance, that we can change modes using an interface for the machine, and also we can capture images while we scan with the robot. Another thing that is crucial for Arthur is that we have a way of detecting whether the images taken from the joints are of sufficient quality, and also whether the disease activities we see in the images, how to actually grade those. So we have developed AI algorithms that during scanning evaluate whether we are in the right position, whether we see the right things in the ultrasound image, and then after the images have been collected, we have a different system that can grade the disease level in the images. And these 2 elements are actually quite important in order to have a system that can perform ultrasound scans automatically. Firstly, it is very important that the clinicians agree on what a standard image of a joint should look like, and what a disease activity in such a joint, how that looks. If you don't have the standardized way to describe the condition, the task of automating that is actually also, or will become, very, very difficult. So lucky for us, the Euler-Omerak rules already existed when we started this development. And in these rules, you have a clear definition of how to image a joint in the fingers, and also what disease activity corresponds to in an ultrasound image. So based on this, we annotated a lot of images, ultrasound images that were collected, and we trained a network to classify these images. And also, and we'll come back to that, we also created a way to actually describe the findings so that the doctors could relate to it. And this is what we call explainable AI. So most of algorithms at that point, they were kind of a black box algorithms where, in this case, for instance, you could put in an ultrasound image and then you got a disease activity score out. But what happened in between the input and the output was very difficult for AI developers to explain. And this, of course, created some concerns in the medical community that what if the system was wrong? What if the image was interpreted wrongly? How can we make sure that this doesn't happen? And so one of the things we did was to actually create these in-between results with segmentation, where the doctors could see the results of the segmentation and see whether the segmentation that they saw corresponds to the anatomical structures that they would see in the original image. And based on that, we could then explain what the system used in order to estimate the disease activity. And this was then implemented in the output from an arthro scanning, where you first got an overview of which joint were scanned and where did we see disease activity. And then for each joint, you will then have the segmented image, and you would have the Doppler or Doppler activity image, and you could then see the doctors could see, well, this looks right. This is the right joint, and I also see that the system actually interpret the images or analyzes the images according to what I also think is the structures we see. So based on this, we could always make sure that the results were understandable for the clinicians, and also if there was something wrong, it would be clearly seen in these images. And so now we have kind of the basic building blocks and iterations in order to go through with the CE marking. And this was not an easy task for the company, and for me, it was my first journey through the process. So a lot of things had to be learned on the way. Retrospectively, the process seems to be quite clear now. However, when we started, it was not at all clear for us. So this is really a process that was a bit chaotic and in times also stressful, but we got through it. And if I had to put some words on how to go about this, I think the definition of the intended use or intended purpose of the device itself is very, very important. And I think that's where the whole process basically falls into place. As soon as you know what the intended purpose of your device is, and that's what you want to develop, it's also much easier to go through the different processes of defining in which category your device is going to be placed, and then based on that, you can then find the right standards and documentation checks that you need to implement in order to comply with the regulations in that area. In our case, it was a CE mark MDR class 2A, mainly dictated by the ultrasound machine interface we had. And based on that, we had to have a quality management system that needs to be supervised by a notified body. So we implemented that. And in that process, we also had to define and get used to a lot of processes, for instance, or a development process based on procedures was something that was not familiar for a university professor. So I had to get a new mindset of how do we actually then do the development and document that. And also in terms of looking at a development process based on a risk management system was also something that we had to get used to in the company. But all in all, I think those were kind of the main learnings from that process. Make sure that you spend enough time on the intended use of your product in order to find the right class. And sometimes it can actually be a good idea to maybe lower the expectation or lower the intended use category in the beginning in order to come go through the process, and then afterwards you can put on layers that maybe enables other features that that would then move you to different classes. So yeah, maybe one advice is to use enough time on the definition of the intended use. Then of course we during the documentation process and development process, we implemented and carried out a lot of clinical tests, and this included patients being scanned by the robot and clinicians and results compared, which is a very interesting process, especially if you come from an industrial robot domain where tests are often done on items that can be quickly replaced. You can get another 100 samples and redo the test. When you do clinical tests with patients, planning of these becomes quite time consuming and important as well, and there are many aspects that you need to take into account when you do these clinical tests. And then mechanical electrical tests. So here, for instance, during the electrical test, Arthur was placed in a testing facility that was maybe a bit overkill in terms of space. So this was I think one of the biggest testing facility for EMC I've ever seen, and I wasn't even there physically, but these images was just mind-blowing at that time. So you have our little robot, but this entire testing facility is very huge, and again, this is time and money. You can imagine having access to such a facility is not cheap. So planning became also vital for the process in order to make sure that we could reach the goals within the budget limit. So I think here also we did quite well, but you could easily have done a lot of wrong steps in this process, and then the entire process would have been delayed a lot. So again, learning from that, make sure that you have the right connections and the right information about which test is needed for your product, and then try to plan that well ahead, because access to these facilities are very expensive, and if you don't get all the numbers you need for the documentation, you might have to redo it again, and that could delay you 2-3 months easily. And then usability test. Maybe this is something in research, at least, we don't spend that much time on, but in a medical device and in the ROPCA story, usability test had huge focus. We had to make sure that the patient understood the instructions, the clinicians understood the instructions, and the use of the robot. We spent quite some time on the user graphics and the user design in later iterations in order to improve the user experience for our user groups. So again, here we probably go into some details in a later webinar, but I think there are quite some interesting things that we learned during these tests. So in order to have some time for questions, I will just come have a few concluding remarks before I open up for questions. I see that time has already passed. So the development of Arthur for ROPCA was actually, it started as a research project. Started very much in a very low ambitious project where we just wanted a robot to hold the probe, but quickly ended up being a project where we had a vision of having a fully automatic system, but due to the complexity of the CE marking regulations with a fully automatic system, we had to go back and redefine the intended use to be a system where you have clinicians or healthcare personnel in the vicinity of the robot and who could help the patients. And based on that, we ended up with a system that currently has a class 2A in the MDR scheme. We learned a lot based on the different steps that we had to go through, and we had to learn it on the fly. And if you sit with ideas of doing medical robotics or applications or devices for medical robotics, I think really consider the intended use. You can save a lot of time by defining the intended use correctly, because that will influence the rest of the process, and that journey would have huge impact on the way your company will or your idea will be materialized in the process. So yeah, with that, please feel free to raise any questions you have, and I'll try to answer best of my abilities. Any questions? Okay, that's a question here. How much time and effort did you save by switching to KUKA medical robot? Yeah, that's a good question. A lot of time. So the KUKA robot had some of the certificates needed for us to go through the CE marking process a bit faster than compared to the UR robot. I think, and this is of course an estimation because we did not go through with it in with the UR, but I think we probably saved around a year or maybe a year and a half of test and documentation with the universal robot arm if we had kept that arm for the product. And the reason why I estimate that is that that includes our learning process, because for the UR arm at that point, we are talking about 2020. We did not have an idea of what was needed. We needed to investigate that part and include that in the planning process. So we could cut some corners in the documentation path by choosing the KUKA robotic arm. So I hope that answers the question. Any other questions? Okay, so if we do not have any further questions, then we will conclude this webinar. Thank you everyone for joining, and I wish you a nice weekend. Thank you and see you soon.